The second part of my lecture will deal with the therapy itself. And there is a choice of the peptide, kidney protection, tumor and organ dosimetry, and monitoring of toxicities. These are the most important issues. I would like to start with the first patient I have treated, at that time still in Frankfurt University Medical Center in '97, shortly before I left to Bad Berka. And this was a boy of 15 years after therapy with MIBG chemotherapy. And you see here the boy after chemotherapy in a very bad shape. And the oncologist said probably survival is about 6 to 9 months only. And there was no other therapy. So I came back from a congress in the United States and heard about this peptide radionuclide therapy. And I just checked if the patient was positive for somatostatin receptors. And you see it was strikingly positive. This is his primary tumor. He had many bone metastases, skull metastases, liver metastases, and so on. And this is, then we started with this yttrium-90 DOTA-tox therapy on him. At that time we received the activity from Basel, where this agent was developed by Helmut Mecke, who is a radiochemist. And this is now 2 years after the first therapy, so not 6 to 9 months. And we went on, this is February 2000, after the fourth therapy, and you see the reduction of the tumor mass. And this is a clinical course, so there are now 5 years in between the first therapy and this picture taken from the patient. And at that time, he was not able to walk anymore because metastases had, went into his spine and has compressed the spine. So he developed what we call paraplegia and needed a wear shield. And then we did something really crazy. We said, okay, why not injecting all the activity in this one metastasis in the spine? And our interventional radiologist, with his catheter, went to this metastasis, and we injected all the activity, and there was a very good uptake. And after that, you see the patient started walking again, even jogging and playing soccer. Though this was now, if you remember, more than 6 years after the first therapy. Okay? And that was so impressive for me, this special case, that I said, okay, this therapy might be really of great benefit to the patients. And when I was in Bad Berka, we then started with a few cases in '99, in 2000. As you can see here, in 2002, only 14 cases. And last year, we treated 454 patients, and this year we will treat more than 500 patients in our center. So it was deeply growing, and that tells you something about the success of this therapy. So our, what we call Bad Berka concept, is based on selection of patients according to clinical aspects, molecular features, for example, if this is a progressive or uncontrolled tumor, and the somatostatin receptor expression determined by PET-CT. We use frequent cycles, so about 4 to 6 cycles and up to 8 cycles of low or intermediate high therapy, what we call long-term low dose, not short-term high dose. This is in clear contrast to what was propagated, for example, by Basel. They did 2 big, hammer hits with very high activity within 6 or 8 weeks, and then left the patient alone. And I think this is not, appropriate for such a slowly growing tumor, but what we have to do is that we have to use this therapy for a long term in these patients. And also, we were the first in the world to use combined Y90 and lutetium-177. Y90 is a quite, hard beta emitter with a range of 12 millimeters, whereas lutetium is a soft beta emitter. And lutetium was propagated by the group in Rotterdam, and Basel was propagating yttrium-90. So also intraarterial therapy for inoperable primary tumors was developed in our center. Then another very important feature, I think, is that we do standardized evaluation before therapy and systematic restaging. So all our patients come again after about 4 or 6 months, and we have again a PET scan, and we look if there is another therapy necessary. And all this data are entered in a prospective electronic database. And the management, as I mentioned, is controlled by a multidisciplinary team of specialists. These are the numbers. We have treated now until September 1st last year 543 patients with 1,600 therapy cycles. Meanwhile, we are over 2,000. About 893 of them with yttrium-90 and 734 with lutetium-177. One very important feature I just want to point out among the histology, immunohistochemistry, Ki67 and all what I mentioned is the kidney function. And I think our center also was the first to point out that it is not enough to measure just creatinine or something in blood which tells you something, but also you have to do what we call kidney scintigraphy, because as you can see here, in nuclear medicine, we can image the kidneys and we can get time activity curves and see how is the activity going in the kidney and how is it excreted. In this case, there was a normal creatinine, but as you can see here, there is an obstruction of the kidney. So if we give a high, therapeutic activity, in this case, it would destroy the kidney. But when you insert a stent, for example, and you get rid of the obstruction, you can treat the patient. Then the choice of the radionuclide, just to give you a little bit of physical characteristics, lutetium-177 has a long half-life of 6.7 days, but a short path length of only 2 millimeter in tissue. Now 1 millimeter is about 1 million tumor cells. So 2 millimeters are still a lot of tumor cells which can be hit. And Y90 has a half-life of 2.7 days and 12 millimeter path length. So it's more for larger tumors. This is a more appropriate treatment. This is our procedure, which shows you the studies done before therapy, like renal scintigraphy, GFR measurement, and the receptor PET-CT, usually within 2 days before therapy. Then we infuse an amino acid solution to protect the kidney and something which is called cello or cellofusin. And then the activity is given into the patient via IV administration over 15 minutes. And after that, we start with what we call dosimetry, that are whole body scans, to measure the activity in the patient. This is a kidney protection protocol. I do not want to go into detail with it, but these amino acids can reduce the uptake of the peptide in the kidney by about 30 to 40%. And it's also by this cellofusin, which is a drug usually used in emergency medicine as a plasma expander, also can reduce the uptake. And that is very nicely shown by a study from Marion de Jong from Rotterdam. She used, microspect and rats, where she injected, in this case, again, indium dotaoctreotide. And you see the uptake in the kidney here, and after giving this plasma expander, this cello, you see the very much reduced uptake in the kidney. That is how nuclear medicine works today, that we have, very smart animal experiments. We can test if the method works and then go into the patient, and our center was the first to use it routinely now. So dosimetry means we want to really follow the activity in the body. This is done after 10 minutes. So when we inject the patient and put the patient under a gamma camera, you can make a whole body image, anterior, what you see here, and posterior view. And you see after 10 minutes, nearly all the activity already has targeted to the liver metastases in this patient. And there is already excretion into the bladder, but there is also some activity here in what we call the blood pool. Now, if you go 80 minutes after injection, not even 1.5 hours, you see everything has cleared already from the blood pool into the liver metastases and the bladder, of course. And then this is 1 hour and 4 hours after injection. You see it's further going. And if we make images after 80 hours or 120 hours or even longer, you only see the tumor in these patients. Like is shown here, 47 hours after injection, you see just uptake in the liver metastasis. Now we can quantify that. You know, nuclear medicine is a tracer technology where we can follow up very accurately the activity by what we call dosimetry. That is, we are making regions of interest over the tumor and the normal organs, and then we get curves, and from that we can, by mathematical calculation, really measure what is the dose in the tumor. For example, we also can measure the uptake in the kidney very accurately. Now, in future, we will be using PET-CT before therapy to measure exactly the uptake and then calculate the dose prospectively. We can use yttrium-86, which is also a positron emitter, for doing that, or something we have developed for the first time in the world, and that was just a few days ago, actually, when we first used it, which is called scandium-44, which comes also from a generator, and this generator has a half-life of 50 years. So you buy one generator and you can use it for 50 years in your patients, and gives you wonderful images. Okay, this is after 18 hours after injection, because this has a longer half-life. The same patient now imaged with lutetium. Lutetium also has what we call a gamma emission, so we can do very nice whole body scans, and you can control where your radioactivity under therapy is going 18 hours after injection. You see it's targeting in this patient a lot of liver metastases. Kidney studies, just to remind you, because many people think, oh, this peptide therapy is so toxic for the kidney. But if you compare it to the standard, which is chemotherapy, for example, streptozotocin and doxorubicin, you see the renal insufficiency is 7% in these patients receiving chemotherapy, and it's less actually than 1% in those receiving lutetium therapy. These are data from Amsterdam in actually several hundreds of patients. Okay, we have different issues. I want to skip that. We have measured that very accurately in our center using yttrium-90, lutetium, or the combination, with a long-term follow-up of more than several years. And you see the fall over time is really minor, is between 6.7 and 15.9%, depending on the median fall per year. So there is patients like this one who received 30 gigabecquerel, 7 cycles, and you see at the end of the therapy his renal function was as good or even better if you look at the GFR, for example, as for beginning of therapy. Though this kidney protection really works, and we have no renal insufficiency seen in any of the patients with a normal kidney function before. Again, this is a patient with a large pancreatic tumor and liver metastases with a normal kidney function after 7 cycles, and this patient could do motorcycle biking 2 days after therapy in the Alps, as you can see here. It just tells you this patient are tolerating the treatment very well. It's not like chemotherapy where you lose your hairs and you are really feeling sick, but it's something you are really profiting. Concerning hematological toxicity, we have seen no grade 4 toxicity. Mostly we see erythrocytopenia, grade 1 anemia in the patients. These are our overall response after 3 cycles of therapy. All these patients were progressive before radiopeptide therapy, and you see 50% have complete remission, partial remission, or minor response. 42% have stable disease, and only 7.5% have progressive disease. And there are no real significant difference between different tumor types, as is shown on this graph here. This was our youngest patient we have treated, a small boy with a hepatoblastoma expressing strongly somatostatin receptors. And stable disease is shown here on the MRI in March 2006, and 1 year later you see no significant increase of tumor size. Actually, some of the lesions decrease a little bit. And what is very interesting, if we look at the paper from Baum in Journal of Clinical Oncology last year, and this was the largest study ever published on neuroendocrine tumor patients. You see, of course, that patients with progressive disease have a bad prognosis. But if you look at this here, it's very astonishing. CR, PR, and MR, and SD, that means stable disease or minor responses, they all have the same prognosis. A very good prognosis, actually, if you compare that with chemotherapy. What does that mean? That means only that morphologic imaging, which was used in Rotterdam, to define the CR, PR, and so on, is not working. Cannot differentiate these different groups, because, as I said, tumor size doesn't tell you what's going on in a big metastasis. There can be 50, 60, 70% necrosis, and the diameter is not changing. So, in fact, from a biological standpoint, it would be a response, but if you measure it on the CT, it's just stable disease. This is another patient, a female, 35 years old. She was an active researcher in biology, and you see she has a lot of liver metastases from, again, a primary pancreatic tumor. And she sent me a postcard 1 week after therapy from Africa, where she were doing her research on monkeys, from the Rubensaurus. And again, it just tells you, you can even leave to, areas where there is no medicine around after the therapy, and she returned safely. Okay, this is a patient with a large metastasis in the liver, in the pleura, in the thoracic cavity, and we treated the patient several times. So after first therapy, and this is before second therapy, and 6 months after third therapy, and you see there is decreasing uptake in the tumor lesions. And she was visiting us again last week, so about 1.5 years after the last therapy cycle, and she's still in complete remission. This showing our overall mean progression-free survival time in 124 patients, and that was 44 months. That is a mean progression-free survival compared to an overall survival of 46 months in the Rotterdam group. So our data seem to be better using the combined yttrium-90 and lutetium therapy. For radiation oncologists, it might be interesting that we are using a combination of internal peptide radionuclide therapy and external radiation therapy in form of intensity modulated radiation therapy, which is called COMBIRD. And this shows you, for example, the CT plan, the CTV based on the CT plan using morphologic data, and what we call the biological tumor volume based on the PET plan, also regarding the data from the somatostatin receptor PET-CT in this patient. And I remember this patient very well because it was actually the first patient I had seen as a student participating in a surgical procedure in the 70s. And she presented about 30 years later as a patient to me in our center, just by chance. And she had a glomus tumor, and the glomus tumor, recurred many times, and she had 13 operations. And then the surgeon said, we can't do anything more. And you see this tumor is causing what we call a facial palsy, or, damaging of the facial nerve, which makes her open eye, and this hanging mouth here. So after the therapy, she could, you see some reduction of this palsy, but after the combined therapy, there is a full smile, so the muscles are working, and she could also close her eyes again. So very good success, which you also can see clinically. And I think a new road we are going now is that we are using this therapy at an earlier stage. And one example is this 30-year-old female. She refused chemotherapy of her inoperable pancreatic neuroendocrine tumor because her mother was suffering from a breast cancer, and she had seen all the deleterious effects of chemotherapy with hair loss, vomiting, and she said, no, I don't want this, never. You know, I prefer dying of this tumor instead of getting chemotherapy. So we said, okay, we will try it as the first method of treatment because surgery was not possible. Chemotherapy she refused, and there are no other treatment modalities. So we gave her a high dose of 6 gigabecquerel of yttrium-90 and then a second one. And you see there is a significant reduction in the uptake, and although this is reflected by a significant reduction in tumor size on the CT scan. And at that time point, our surgeon said, okay, now I can try to operate on her because the tumor has shrunken so much, and it was possible to remove the duodenum by a so-called Whipple procedure, and these primary tumors and the metastases, which were shown to contain mostly necrotic tissue, what we call radiation necrosis. And fortunately for the patient, now 12 months after surgery, she is completely free of disease without any damage. So in conclusion, this peptide receptor radionuclide therapy is effective even for very advanced cases and leads to significant improvement of clinical symptoms. Cure is rarely possible because of the heavy metastasized patients, but good palliation can be achieved. And in patients with progressive neuroendocrine tumor, combined sequential yttrium-90 and lutetium-177 PRRT is most effective because we have seen the highest percentage of partial remission and stable disease. Significant kidney damage can be reduced or avoided by extending the treatment intervals and by using lower therapy activities more frequently using our Bad Berka protocol. And PRT should only be performed in specialized centers as these patients are frequently very ill and need interdisciplinary treatment and long-term care. At the very end, very shortly, I want to present work in progress because that's extra for you, Bill. I know you are, very much computer guy and on the internet, and you said you will propagate this by internet. So what we are doing in collaboration with the University of London, Ontario, is that we are establishing an electronic database where, all these patients around the world can be entered in a structured way. And by that, we can really gather all the data, not only from Europe and United States, but also from countries like here. And in Germany, we have already started with this, with a net registry, where more than 10 centers are participating, entering the patient data, and then in 2 years or so, we will have enough patients to really make a thorough evaluation. This is our team in Bad Berka, our radiochemist, Mr. Wottmann, all the nurses and, technologists and my colleagues helping me on this way. So I'm speaking here, but it's really a group work and a combined work. And I would like to finish by showing you the flower you all know here, which I have seen in the beautiful Botanic Garden in March last year. Thank you very much for your attention.